Hello, welcome all to the Intravascular Imaging Academy. And in this session one, I would be discussing about the basics of the OCT. So nowadays, we most of the center are using the imaging to optimize the PCI. So first of all, I would like to dive into the basics of this imaging, what actually optical coherence tomography means. So it is with this presentation, with these sessions, we'll know about the basics and about the image interpretation and then the case-based learning. So in this picture, just to show what is the importance of the different type of imaging, on the top we see there is a thermal imaging and an ordinary photograph at the bottom. The plastic bag is mostly transparent to the long wave infrared, but the men's glass are opaque. So it depends upon what we are looking and with what method we are looking at the image. So this is how is nowadays we see the Illumian OCT system in cath labs. And but it's a very age old. It has been a decades of research and excellence that has been there. Around 1990, two Japanese researchers, Dr. Nahori and Dr. James D. Fujimoto of the MIT in US, applied for the patents in 1991. And in vitro observation of the retina and coronary artery was done in 1991. And 1991 marks the first use of OCT in human coronary observations. And OCT was clinically applied in ophthalmology in 1996, but now nowadays it is has got a lot of use in the coronary as well. And we have seen the evolution of various OCT catheter system. So this is how coronary looks like on conventional angiography. And this is on the right side what we see from the what we can say we are getting inside the tunnel of the coronary artery, and we are seeing with the optical fiber lens. We are converting these signals into analog signals, and we are able to see the linear or longitudinal section of the artery as well as the cross section structures. Initial days, time domain OCT was developed, but that needed occlusion of the artery to get rid of the blood. But nowadays, we are using frequency domain OCT. I'm not going into the this details of the mechanism, but just to understand that once we engage the artery, we cross a wire, and over this, we take our this imaging catheter, and distal it is the tip marker or point A. We can see in middle the lesion should be crossed by the lens marker, which is point B, and this is a length that is a pullback length from distal to the proximal marker. This sensor lens will move and will have the imaging from the distal to the proximal. So just to show a random image that what we acquire patient in having this post-stented patient coming with the inner century stenosis. So this was how it was done. So I'm not going into the detail, but just to give a brief introduction how a live OCT looks like. So this is again a different case. So OCT is actually optical coherence tomography. It's an optical live coronary biopsy, and there is a high level of accuracy and real-time full tomographic measurement of the tissue microstructure can be done. It has a high imaging axial resolution, and it uses near-infrared optical fibers, and there is a significant correlation between the findings and the histological examination. So, what is the basis actually in cross-section images that are generated by measuring the echo time delay and intensity of light that is reflected on backscatter from internal structures in tissue, and a shorter wavelength of the imaging light when compared with ultrasound improve localization of the retarded signal. So three important things: how does the intima looks like, how does the media looks like, and how does the adventitia. So it is almost similar like to intravascular ultrasound. It is bright, dark, and bright. So intima is signal-rich layer near the lumen, and media is signal-poor layer in the middle of the artery, and adventitia is the signal-rich outer layer of the artery wall. So we can see on the right side, the intimal layer is bright. It is signal-rich. After that, it is a signal-poor, and after that, it is again a signal-rich. So it's signal-rich, poor-rich, bright, dark, bright. So we can more clearly see in this cross-sectional image There is a catheter, there is a wire, and this the aesthetics is the wire artifact. And on this, near the catheter, we can see the three layers. And we should also know how to identify the various structures while we are looking for it. For calcification, it is we can see the this for coming on first to the fibrotic tissue, it is homogeneous, high reflectivity, and low attenuation. So we can see in the figure A, the tissue, the bright tissue in the intima has thickened, and this tissue is homogeneous and high reflectivity with low attenuation. In this figure B, we can see there is a sharp edged structure from 3 to 6 o'clock, which has a low reflectivity or low attenuation, but the edges are sharp as compared to the lipid plaque, which is mainly this diffuse edges. It has high attenuation. So that is how we differentiate between the this calcium and the lipid. Next comes the thrombus. It is mainly a luminal thing which is got a medium reflectivity and high attenuation. One margin is high reflectance, and behind that there is a high attenuation. And white thrombus is again got a medium reflectivity and low attenuation. So this is how a normal artery looks like. The figure B shows a red thrombus in which one side is brighter, and after there is a attenuation, the high attenuation is seen. And on the figure C, you can see this suggests some disrupted tissue is adjacent to it, and it is may have led to a rupture due to thin cap fibroateroma. So there are difference between OCT and IVUS. IVUS is ultrasound, whereas OCT is near infrared. Wavelength uses 1.3 micron as compared to 35 to 80. Resolution is around 10 micron, whereas compared to 100 micron in IVUS. And the frame rate is 15 to 20 per second as compared to 30 per second in IVUS. And fallback is 1 to 3 millimeter per second as compared to IVUS, which is 0.5 to 1. So, but the depth of penetration is less in case of OCT, having the higher resolution where the penetration is up to 10 millimeter. So for larger artery, IVUS is preferred. For left main, IVUS is preferred. But for rest of the places, OCT is a better modality. So this is how we can compare with the IVUS with the OCT. On left side, we see a central catheter. On right side, we see this catheter. Post-Stokes shadowing is almost same, but we can see dark, bright, and this is intima is a bit single layer, and after this is a dark shadow that is median. After that, it is adventitia. On right side, we can see this trilaminar structure, intima, media, adventitia can be clearly seen in this OCT image. So for any assessment of the vessel for native artery, and you see on the luminal side, you find a high attenuation, that's the red thrombus, low attenuation or bright structure is white thrombus. And if it is attached to the wall, if it is high attenuation, then it is lipid. And if it low attenuation with good margin is the calcium. So there is one word about thin cap atheroma at the atheroma site, and if you see that if you measure the thickness of the cap, if it is less than 65 micron, then it is more prone for rupture and erosion, and it is called as thin cap fibroatheroma less than 65 micron, and it usually is associated with large lipid cores, more than 50% of the plaque volume, as well as the macrophage density is more, and this is a one level plank. So this is again an image. Once the post PCI image, you can see there is a central catheter, and we can see the stent struts, and which has a shadow. So it is figure A is well opposed. In figure B on OCT, we see the stent struts are not opposed to the intimal surface. They have a this distance more than 200 micron. Or in figure C on IVUS, we can see it's well opposed, but on the right lower D, we see the stent struts are not opposed to the lumen. Again, they are more than 200 microns, so it's called a malapposition. This is again a slide showing the malapposition of the struts. The struts are far away from the intimal surface. And many times we can see this in stent dissection, but it is of no clinical significance until unless it is present at the edge. And many times tissue prolapse looks like this tongue-like projection or conical projection within the that is coming protruding inside the lumens when we have implanted the stents. At all of the places, the stent looks opposed, but there is some conical tissue, convex tissue coming, and this is called as the tissue prolapse. And many times the patient develops a stent thrombosis, and this is actually a mixed type of thrombus. In the stent thrombosis combination of red and white, mainly it is white thrombus. So, a long-standing the stent can also have the this instant restenosis, and mainly the fibrosis can occur or neoatherosclerosis can happen. So they can see the bright structure. This is mainly fibrotic, and we could see the stent struts behind this. So this was all about the basics of interpretation of the image. Now I would be discussing about the intravascular imaging, that is OCT, mainly as a case-based learning. So in the next session, I would be discussing the various cases, and we would be interpreting the images. So thank you all for patient listening.